Hi friends, I'm back again with another video. The last video that I shared was on DSDs and congenital adrenal hyperplasia, and I received a very warm response. I'd like to thank you all for it. So here on my channel, I'm just trying to mystify topics that kids find confusing. Even I used to find them confusing when I was in MBBS. It was only when I studied OBG in depth did I get some clarity on it, and hopefully I'll be able to pass it down to you people so you find it easier to remember things that will help you in your exam. So today we are going to talk about RH negative pregnancy. We are going to talk about RH negative pregnancy, and right before we dive into it, I want to ask you all a question. And the question is this. A Gravida 2 Para 1 Living 1 presenting to you in the OPD at 20 weeks period of gestation has a negative blood group. Her husband blood group is positive and her ICT titers are given to you. It is given as 1:4. How will you manage her? And the options are: you will give her an injection anti-D at 28 weeks. You will do a weekly MCA PSV monitoring on ultrasound. You will do monthly ICT titers, or you will go for an intrauterine transfusion. So just keep your answers in your head. We are going to come back to this in a bit. So let's just dive right into this, and hopefully by the end of the session, you will be able to solve not just this question, but any question in RH that is thrown at you. Yeah. So RH negative pregnancy, what exactly do I mean by it? It means that the mother's blood group is negative. So she may be A negative, B negative, O negative, whatever. So if the husband's blood group is also negative, that is not very problematic. But if the husband's blood group is positive, then we know that there is a chance that the fetus or the baby that she has might have a positive blood group, right? So the baby might have a positive blood group. So why is this at all a chapter? Why is this a chapter? Because this may cause a problem. And what is that problem? So this is our RBC. And RBC, depending on what blood group you have, for example, my blood group is B positive. So what that essentially means is that I have a B antigen coating my RBCs and positive. So I have an antigen that makes it positive. So this antigen, let's call it D antigen. So if I have a B antigen and a D antigen, it means my blood group is B positive. Similarly, if there is a person who has an A antigen, a B antigen, and a D antigen, their blood group will be AB positive. However, if a person has, for example, just the B antigen and no D antigen, that will make their blood group B negative. This will make their blood group B negative. Now, what will happen is we know the immune response of the body is such that whenever a foreign antigen is encountered in the bloodstream, the body tries to protect against it, right? So, if there is a mother who has a B negative blood group, she has B antigens. If by chance, by way of a blood transfusion or anything else, she is exposed to blood that has RBCs which are coated with any other antigen, for example, A antigen, what the body will do is it will mount an immune response that will try to destroy this foreign antigen. So what it will do is the body will identify this foreign A antigen and make anti-A antibodies. It will make anti-A antibodies. Similarly, in an Rh negative mother, if she is by chance exposed to a positive blood group, which means this RBC that she is being exposed to has a D antigen, then the body will start making anti-D antibodies, which will help to destroy this foreign antigen. So this is the problem that we are facing in a pregnancy where the mother's blood group is negative, but the baby's blood group is positive. So in case there is any feto-maternal hemorrhage or any mixing of the baby's blood and the mother's blood, what the mother's blood is going to do is, the mother's body is going to mount an immune response that is going to create anti-D antibodies. The mother's body will create anti-D antibodies. And what these anti-D antibodies will do is, it will coat itself on the fetal RBCs that have the D antigen and destroy them. So what is basically happening is The mother's blood is destroying the fetal RBCs via the anti-D antibodies, and this is leading to fetal anemia. So this is the problem that is happening in Rh negative pregnancies. Now, the thing is, this immune response that is happening, we know that the first response of the body's immunity is always IgM. This is the acute phase reactant that we have. And this reaction usually takes around, it can take from between 6 weeks to 12 months to form. And we know that the IgM is a big molecule. It is a pentamer. So because it is a pentamer, it is a big molecule, it is not able to cross the placenta. So if the mother is exposed to some fetal blood in her first pregnancy, at most what will happen is either the antibodies will take time to form and her pregnancy might go by unscathed because the antibodies have not formed yet. Or her antibodies may form, but only IgM is formed, which is not able to cross the placenta, hence not able to destroy the fetal blood cells. But what happens in the subsequent pregnancy? What happens in the subsequent pregnancy is, now this mother, she had a reaction and she has made IgM anti-D antibodies in her first pregnancy. By the time she has her second pregnancy, the body has identified this antibody, and the moment there is even a tiny exposure to fetal blood in the maternal bloodstream, what is going to happen is the body is going to mount a huge immune response. And this time, the immunoglobulin will be IgG, which crosses the placenta. So this is going to cross the placenta and it is going to destroy the fetal RBCs, and this is going to cause fetal anemia. So this is the problem that is happening in Rh negative mothers, right? So what can we do to prevent it? The basis of prevention is this. The moment we expect or the moment there is certain bleed which alerts us to the possibility that there might be some feto-maternal hemorrhage, what we can do is we can quickly try to neutralize the fetal blood cells that have entered the stream. So for example, if there is any feto-maternal hemorrhage, for example, the mother has just presented, she's an Rh negative mother, her husband's blood group is positive, so there's a possibility that the baby might have a positive blood group, right? So she has presented to us with feto-maternal hemorrhage. So what do? Is we know this is the maternal bloodstream and there are maternal RBCs and there are, I'll make this the fetal RBCs, right? So this fetal RBC, when it reaches the mother's immune system, it is going to create this response wherein immunoglobulins are going to be formed. So what I do is I try to neutralize these RBCs so that they are not able to reach parts of our body which mount an immune response that identify. So basically, I'm going to neutralize this so that the B lymphocytes do not identify this foreign D antigen. And what do I do for that? I give anti-D. So there is D antigen, I want to neutralize it so that it does not reach the B lymphocytes. So I am going to give anti-D. And this is available to us in the form of an injection anti-D. And we give this whenever we are suspecting a feto-maternal hemorrhage. So this helps in the prevention of what we call iso or allo immunization. So this anti-D is preventing isoimmunization. So what do? When a patient comes to us in the beginning of a pregnancy, she comes to us and, for example, her blood group is negative. The first thing we want to do is we want to find out, is there a possibility that the baby will also have a positive blood group, right? So what we do is, the next step that we do is we get the husband's blood group. So if the husband's blood group is negative, well and good, the baby is also going to have a negative blood group and there's not going to be any isoimmunization. So we will treat this as any other normal pregnancy. However, if the husband blood group is positive, there is a chance that this baby's blood group may be positive, right? So what do we do next? Do we start with our plan of anti-D? No. Because anti-D is useful only when isoimmunization has not already occurred. So the next thing that we need to find out is, has isoimmunization already occurred or is it yet to happen? So if it has already occurred, my friends, anti-D is not going to be of any use. So the next thing that we do is we ask the question, is isoimmunization already done? So, if isoimmunization is already done, then there is no point of anti-D. No point of anti-D. And this we will treat, which we will come to later, as an RH isoimmunized pregnancy, which is totally different from a pregnancy that is RH negative and not isoimmunized. So, how do we find out has isoimmunization occurred? So, for this, we have a test which is called indirect Coombs test. ICT or indirect Coombs test. So we have two tests, one is indirect, one is direct. So the indirect Coombs test we are doing on the mother, direct Coombs test I will come to later, we do that on the baby's blood. So why is this called indirect Coombs test and what are we doing in it? So basically what we are doing is we are taking the mother's serum. So we are taking the maternal serum. We don't know yet whether it has anti-D antibodies or not. So basically we are checking the maternal serum for anti-D antibodies. So what we do is we take any other positive blood group RBC that we already know. This is the test. This is the thing that this is the substrate on which we are putting the maternal serum. Then we put the maternal serum in it. So if we put the maternal serum in it. So what happens is, if the maternal serum has anti-D, then it is going to clump these RBCs. These are going to clump these RBCs. So if D antigen we already know is present on these RBCs, the maternal anti-D antibodies stick to it. And then what we do is, to see whether this anti-D is present or not, we have another substrate, another testing reagent that we call anti-human globulin, AHG, anti-human globulin, which is basically an antibody against human immunoglobulins. So what we do is, this anti-human globulin, when it detects this anti-D, which is coated on the test RBCs, it starts clumping. And therefore, we know the ICT is positive. Obviously, if the ICT was negative, which means the anti-D is not present in the maternal sera, because there would be no anti-D, the anti-human globulin would not bind to anything, right? So this means ICT is positive. ICT positive means isoimmunization has happened, and ICT negative means isoimmunization has not yet happened. So if isoimmunization has not yet happened, that is where our prevention comes in and we can plan our anti-D. So when do we give this anti-D? So the anti-D is given at 28 weeks. It is given at 28 weeks. Why is it given at 28 weeks? Because the percentage of feto-maternal hemorrhage that is happening is very less before 28 weeks, right? So at 28 weeks, we give an anti-D. And then we repeat this anti-D again after delivery. We repeat this anti-D again after delivery. And this should be done within 72 hours of the delivery. But if you miss, and this is a clinical thing, if by chance you have a patient who has come to you after 72 hours and she is RH negative, not isoimmunized, then what we do is we give it to her, we can give it to her up to 28 days as well. So do not miss the chance of giving anti-D to a patient even if she has come late. And what is the dose of this anti-D? So we give injection anti-D 300 microgram, which actually corresponds to 1500 international unit. We give her 300 microgram, and this is given intramuscularly. And my friends, remember this. This is a very important question. This is given over the deltoid. So we know IM injections we can give over the buttocks, we can give over the deltoid, but this is given particularly over the deltoid because it has been seen that due to a lot of fat in the buttocks, sometimes the absorption is varied and we do not get the desired effect. So this is given over the deltoid. So this is in a patient in whom we do not see any feto-maternal bleed. So this is something that we are doing routinely as a prophylaxis. However, if you see an obvious cause of feto-maternal bleed, for example, if she has a threatened abortion, right, or she has an abortion, or you do any invasive procedure like CVS, like amniocentesis or cordocentesis, or there is abortion, we also have to give an additional dose then. And the dose and dictum for this is if there is any procedure that is happening before 12 weeks, be it an abortion, be it a CVS, then you give 120 microgram of anti-D, right? 120 microgram of anti-D. And after that, if it is happening, not at 28 weeks, but after that, if it is happening, you give 250 micrograms. At 28 weeks and postpartum, we give 300 microgram, which is corresponding, again, I'll repeat this, to 1500 international units. 1500 international unit, right? So this is what we do. This is what we do. So this anti-D is actually another question that is asked to you. It is effective for how long? It is effective for 12 weeks. So if the mother, 28 plus 12, 40 weeks, if the mother is delivering after 40 weeks, then you might need to give an additional antenatal dose of anti-D to prevent ICU immunization. Similarly, if today she turned 28 weeks and I gave the mother an anti-D, but she went into preterm labor and she delivered at 30 weeks, if there is not a lot of feto-maternal hemorrhage, then I do not need to repeat the anti-D because it is so close to the date of administration. Right? So this is another concept that you need to know. So now we have treated this as a normal pregnancy. The only thing that we have done is we have given her a routine prophylaxis of anti-D at 28 weeks. So when do we deliver her? We induce or deliver as a normal pregnancy. That means we can go up to 40 weeks easily. We can go up to 40 weeks, right? So at 40 weeks, we will induce her. And after this, once the baby is born, do I have to give her an anti-D? Like I said, postpartum period, in the postpartum period, we are giving her anti-D. Do we have to give her an anti-D? Can you think of any condition where I don't need to give her an anti-D? One is if the baby blood group is negative, then obviously there has been no ICU immunization, no chances of ICU immunization, then we don't give anti-D. But if the baby blood group is positive, then what do we do? If the baby blood group is positive, do I necessarily need to give an anti-D? Again, it is not necessary. And this is a variation of a question which they might give to you, not in NEET, but in INI, they might give this to you. If the baby blood group is positive, I do not necessarily need to give anti-D. So what will decide whether I need to give this anti-D or not? We conduct a test which is called the direct Coombs test. We talked about the indirect Coombs test. Now we are going to talk about the direct Coombs test. Direct, it is directly being tested on the fetal RBCs. So what we are doing is we take the baby's blood. So we take the baby's blood. The baby's blood, we know, has D antigen. And if isoimmunization has occurred, then there will be some maternal serum and some maternal anti-D already present. So the maternal anti-D is present. Then what we do is we take this baby's blood, which already has the RBC and the maternal anti-D, and to this we add the reagent that we talked about, anti-human globulin, and this is going to cause clumping. So if the DCT is positive, which means the AHG finds a substrate, it means isoimmunization has already occurred, which means if DCT is positive, isoimmunization has occurred, and now, unfortunately, there is no point of giving anti-D. Same thing if the baby's blood group is positive but DCT is negative, which means isoimmunization has not occurred but may occur. So we proceed to give the mother anti-D 300 microgram. Anti-D 300 microgram. So this is mostly it. This is basically all the things that they can ask you from Rh negative, ICT negative pregnancy. The only other thing that they can ask you is about something called the KB test or Klehor-Betke test. So this is a quantitative test. And why do we need it? It tells us the amount of feto-maternal hemorrhage, more specifically, the amount of fetal bleed. The amount of fetal bleed. Now, why is this important is that this 1500 international unit or 300 microgram of anti-D that we are giving is basically going to neutralize only 15 ml of fetal RBCs. Now, this figure has been reached and this formulation has been reached according to the average feto-maternal hemorrhage that takes place. But there may be conditions where the feto-maternal hemorrhage is so large that this amount of anti-D that you are administering is not enough to neutralize all the fetal RBCs. So if there is any additional feto-maternal hemorrhage, which may be expected in the case of cesareans or in case of abruption or placenta previa, where we know the feto-maternal hemorrhage is more than usual. In that, depending on how much feto-maternal bleed there is, based on what we see in the KB test, we might have to administer extra anti-D. So what is basically happening in the KB test is that we take the maternal blood, so there may be some fetal red cells in it because feto-maternal hemorrhage has happened, and then we add an acid to it. And what acid do we add? This is also a question. We add citric acid. Now, the hemoglobin F that is present in fetal RBCs is very resistant to acid elution, but maternal hemoglobin is not. So what happens is when I add this acid, I will see a background of washed out maternal cells. And in the middle of that, I will see some fetal RBCs, which because of HbF have still retained their color. So HbF presents acid elution. And these maternal cells look like ghost cells. So depending on how many fetal RBCs we see under the microscope, we have formulas by which we can calculate how much feto-maternal hemorrhage has happened. And if there is any extra feto-maternal hemorrhage, we can give anti-D. But this is not routinely used because it is cumbersome. It is not very accurate, does not give very accurate results. And one place where it is particularly inaccurate is, if anybody can guess this, chocolate points, hemoglobinopathies. Because in hemoglobinopathies, we know that the hemoglobin F concentration in the mother may actually be higher than in normal adults, right? If they ask you what is the most accurate way to quantitate feto-maternal hemorrhage, then it is not KB test. Again, the question is flow cytometry. So this brings us to the end of Rh negative, ICT negative pregnancy. In the next part, which will be out tomorrow, I will be dealing with Rh isoimmunized pregnancy. Thank you.